All right, it looks like it's 7 o'clock, so we'll get started. Good evening, everyone, and welcome to the Together We Build Emergency Services virtual town hall. This is the first of a series of conversations that will take place over the next few weeks. We're going to look at 11 program-specific areas of planning for the new Windsor-Essex Acute Care Hospital. Now, before we begin, let's respectfully acknowledge that the Windsor Regional Hospital occupies the traditional, ancestral, and contemporary lands of the Niswi, Ishkoden, Anishinaabe, the Three Fires Confederacy, Ojibwe, Ottawa, and Potawatomi. We acknowledge that the land and the surrounding waters for sustaining us, and we are committed to protecting and restoring these lands and waters from environmental degradation. On behalf of the project management team overseeing Stage 2 planning for the new hospital, we are pleased to welcome everyone joining us tonight via Zoom webinar. I'm Allison Johnson, Manager of Communications and Community Engagement for the Windsor-Essex Acute Care Hospital project, and your moderator for this conversation. Tonight, you will have the opportunity to meet some members of the user groups designing the new emergency department and satellite emergency department. You'll have an opportunity to learn about the work that they're doing and to ask questions. To ask questions, click the Q&A button at the bottom of your screen and then type in your question. And we're going to do our best to answer as many questions as possible at the end of tonight's presentation. Please note the focus of tonight's town hall is Stage 2 planning of emergency services. And this includes items related to the physical structure of the department, its layout, what other programs and services are located nearby, and design features and technologies. To maintain the flow and focus of this conversation, please ensure your questions are related to this and future stages of planning. Following tonight's conversation, we also invite you to participate in our engagement platform, and you can find that at togetherwebuild.wrh.on.ca, and I will put that in the chat feature later on. There you can also ask questions that you didn't get a chance to ask tonight or didn't think of during this conversation. You can also take our surveys related to the planning of emergency services and share your ideas. Now, I want to introduce you to tonight's panel guests. Everyone, please welcome Jonathan Foster, Vice President of Emergency and Trauma Services. We have Kristen Mayu, Director of Emergency Services. We have Dr. Snez Ninkovich, Chief of Emergency Medicine. Lucy Brune, she's a partner with Agnew Peckham Healthcare Planning Consultants and has been working with the Emergency Services User Group team. Bruce Crowder, Chief of the Windsor-Essex EMS, Essex-Windsor EMS, sorry about that. He's also a community representative for this project. And we have June Muir, who's a patient representative for the Emergency Services User Group. We have Dr. Andrew Petrakis, Director of Clinical Services Planning, and Paul Landry, who is Project Director for the new Windsor-Essex Acute Care Hospital project.
Good evening, everyone.
So thanks everyone for being here with us tonight. And at this time, I would like to pass the mic over to Paul Landry, who's going to talk about what's involved in Stage 2 planning and the goal of today's conversation. Paul?
Thank you, Allison. Maybe the next slide, please. So just to put it into context, Stage 2 is part of 5 stages in the capital planning and development process under the Ministry of Health. So we are approximately, as I will show you in the next slide, at approximately 25% of the work involved in Stage 2. The second half of the work for Stage 2 will be undertaken from the months of June right through to the end of the year. Consists of block schematic drawings, the development of those drawings. Stage 3 will be furthering those drawings into indicative schematic design drawings and the preparation of procurement documents to go out to the marketplace. Stage 4 then involves the onboarding of a developer that includes, of course, a construction team, but also architects and engineers to take that indicative schematic design and further it into working drawings. And then stage 5 consists of the construction project itself, which has been estimated to be approximately 4 years. Next slide, please. So in stage 2, we have 3 parts to stage 2. The first part is the development of a functional program, which you will hear more about tonight through a presentation that Lucy will make. The part A of stage 2 involves the development of the functional program. We will be onboarding a team of architects and engineers with us this summer, and they will take that functional program and translate it into block schematic drawings that, as I mentioned earlier, will take us to the latter part of the fall. And that concept plan, as well as the space that is all outlined in the functional program by way of lists of thousands of rooms, of course, in the new hospital, but also in the Willette site with the services that will be planned for that site as well. And that information will inform a group of cost estimators that will then refresh the cost estimate, update it to where we are now with the development of the plans. Those 3 components will then be compiled into a stage 2 submission that we plan to submit to the Ministry of Health next winter, so early in 2023. And with that as a context of the planning phases, we turn it over to Lucy.
We don't go to Lucy yet.
Oh, sorry.
Paul, can you talk a little bit about the goal of what is happening tonight and this conversation? Do you want to set that up a bit and then we'll move on?
Sure. As I mentioned earlier, we are approximately 25% through the work of this stage 2. So we're midway through the functional program planning. Of course, we've formed over 40 user groups, really focusing on each and every clinical service, but all of the non-clinical services as well for the new hospital, as well as the redevelopment of the Willette site. We've had 2 rounds of user group meetings. We've reviewed a first draft of the functional program. But we have, for most of the groups, of course, we have a 3rd round for all of them, but for many of them, we will also have a 4th round of meetings that will take us to the beginning of June, where we should be reviewing the final functional program document. And that document then, as I mentioned, would be presented to the new team of architects and engineers that will then develop the block schematic drawings. So it's early going in this process. We've had 2 rounds of meetings. As Lucy will expand upon, all of this planning is based on forecasting demographic changes, forecasting volume changes well into the future, as she will show in her presentation. So we look at the trends of the past and we forecast for the next 10 years and indeed the next 20 years, the capacity that we require to deliver all of the services for the new hospital system in Windsor. So it's early going, but what we really wanted to do through this community engagement process was to reach out to the community and seek their input on ideas, questions about what we're doing, how that is evolving. And tonight is the first opportunity to really have that discussion, have that dialogue with them around how the planning is evolving. But it's early on, and there will be other meetings in the future, and we'll be able to share more details as the plans actually crystallize. There's lots of discussions now. There's lots of, I shall say, discussions around volumes and exactly what types of services, what types of rooms that will require on both sites. Of course, for the main ER at the new hospital and also the satellite ER at the Willette site.
Thanks, Paul. There really has been a lot of work going on this year. Right since the beginning of January, everybody hit the ground running, these 40 user groups that Paul's talking about. It has been a different energy, and we are excited to share with you over the course of these 11 town halls some of the work that we've been doing. But as Paul mentioned right there, it is early stages. So at times we may not have all the answers, or we may have the answers later down the road. But really what's important throughout all of this is that we are keeping you updated, and that we also get input from you. So I'm going to share once again the engagement platform, and we do encourage you after this to please have your say at that platform as well. So right now, I want to turn things over to Dr. Andrew Petrakis. He is the Director of Clinical Planning on this project, and he sits in on a lot of the groups, all of the groups related to the clinical planning for the new hospital. He's been with Windsor Regional for decades and brings a lot to this planning process. So Dr. Petrakis, I just want you to give this some context. What is the responsibility of the user groups that are planning for emergency services, and how does this work fit into the bigger picture for the new hospital?
Sure. Thanks, Allison, and good evening, everyone. I just wanted to say how pleased I am to be here in the company of our esteemed guests and our panelists taking part in this functional planning group for the new hospital. It's my privilege to sit on the next 10 functional planning groups, the presentations that are going to go on over the next couple of weeks. And I just want to say that the Emergency Functional Planning Group includes local and national experts, those of which you've met this evening, some of which you haven't met. That includes staff, our staff, nursing staff, physician staff, Dr. Ninkovich's emergency physicians, Dr. Bradford, managing trauma care, Dr. Takahashi, Department of Surgery, Dr. Morgan, Department of Pediatrics, and chiefs of other departments that have participated and will participate in these functional planning groups, which are all intertwined to produce the eventual outcome of our new hospital and the satellite Willette site. In terms of what the team is responsible for, well, we're responsible for reviewing and confirming the data that's been collected, that's current, and the future patient emerge volumes based on age and demographic projections to arrive at the required numbers of beds, the space to accommodate our patients in the new hospital. We want to make sure that the areas for nursing and physician and workspaces are adequate. Administration of educational areas are also appropriate. And there's room for housekeeping, nutrition, and we'll also include, as Bruce is here to participate in, the requirements for EMS and ambulance garage at the new site, as well as at the Willette site. The team will be working with the information to group emergency services into treatment areas that Lucy is going to sort of elaborate on and give you a better idea of how we're going to group these services to provide the best patient outcome and best patient flow through the emergency department, both at the new campus and at the Willette campus. Additional group recommendations will be followed on improving patient experiences, but ensuring clear wayfinding through both sites, moving through departments, having services that emerge patients require are easily accessible as well. And finally, I just want to say that the planning team with other functional planning teams are going to coordinate all these efforts to make sure that the patient experience is optimal for everyone. Thanks, Allison.
That's a lot of work. Thanks, Dr. Petrakis. My next question is for Jonathan. Jonathan, what is the vision of this group when it comes to a new model for emergency services? And when you're talking about that, if you could describe the two-site model and how it will work to benefit patients.
Thanks, Allison. And like Dr. Petrakis, I'm really honored to be here, both with our panel and everybody who has opted to take part in this discussion tonight. The vision for our emergency department is have two state-of-the-art emergency departments, one that's going to be located at the new acute care hospital and a satellite emergency department that's going to be located downtown Windsor at the OLET campus. One important note within that model is that both sites are going to be staffed by the same physicians, nurses. The clinical team that works at the emergency department at the hospital will be the same team working at the satellite emergency department at the OLET campus location, as well as a non-clinical team. So they'll have complete familiarity, the same skill set. And the vision really is that both emergency departments are here for our community. I think one important distinction that we have to remember is that about 90% of emergency department visits are not admitted, meaning that they don't need to go to a location that would require admitted inpatient services. And we currently work under a 2-location model between the OLET and Met campus emerges. This plan and the vision for this plan is going to take that model and streamline it and make it easier and faster at both locations for patients. And clearly, we're going to have the more acute and more serious types of conditions and presentations go to the new hospital emergency department, and try to have less acute or less serious conditions go to the satellite location because they won't require the admission. But if somebody were suffering a serious condition at the satellite condition, so were to walk in or go there on their own accord and be presenting with something serious like a heart attack or something that requires resuscitation, that team will have that ability to do that. And similarly, ambulances will also be able to go to both locations, the satellite emerge at OLET as well as the new location. And so when we think about having all of the services under one umbrella at the new hospital location, that's really going to make it easier for things like a fracture that could go to the satellite location and have X-ray capability and be able to be treated, assessed, and sent to the next stage of their journey, or somebody who needs sutures, without having to be an emergency department that's competing with the resource requirements of having traumas come in or the really heavy cases that come through. And the only other thing that I would add to that vision is that working really closely with our EMS partners in our current state, we have destination protocols or clinical criteria for where people go for what location. And that works really well current state. A good example is that somebody who's having a baby, our community really knows that that service is available at the Met campus and they make it there. But in the off case, in the rare instance that somebody does come to the OLET site needing to have that care delivered to them, they would be able to receive that. But working with EMS, we will have that system in place that really directs the volume and traffic of ambulances and how that works. And it might be worthwhile asking Chief Crowder at this point if he wanted to expand on that at all.
Thanks, Jonathan. And 100% correct. Current state today, paramedics, when they pick up the public and decide a destination, we work extensively under destination protocols. And whether it's cardiac, whether it's trauma, whether it's mental health, there's specific locations that are a better location for delivery or transport of that patient. And through education of the public, I can expect that we will determine that the public will understand which would be the best facility to go to. That if you're having chest pain or you're having the signs of a stroke, you're not going to drive yourself to the hospital. You're going to call 911 and EMS is going to take you to the correct facility. But if it's a lower acuity or a more non-urgent or non-emergent, you'd be able to drive either to the downtown site or to the acute center. So thanks, Jonathan.
And can I just add to that, Allison, that in our current state, we transfer a lot of patients between the two locations because of what Chief Crowder just described. We have certain services available at one site that are not available at the other. In this new model, that volume of transfers between campuses is going to drop dramatically. And so as a result, once again, we're going to have more EMS capacity to service the community. And again, I want to emphasize this point. In the rare occurrences that we do have somebody go to the satellite location, they will receive the same care there. And if they need to be transferred to the new hospital location for an admission or for further care, they will first be treated and stabilized at the OLET satellite.
Thanks, Jonathan. And I think it's important to note about the question of how will people know where to go? We've got 7 years and our communication team knows that this is a point that we're going to have to keep talking about. We've been talking about it since 2015, but as we get closer and closer, I know that this is going to be a priority, and we will continue to communicate this. My next question is for Dr. Ninkovich. What will this new model mean for the patients that you see?
I think this new model is very exciting in terms of the fact that it now allows us as physicians to deliver more efficient services to our patients. Mr. Foster touched on the fact that all services would be provided under one roof, again, minimizing the number of transfers we do between sites. This model will also allow us to provide more specialized care. So we're doing some focused looking at pediatrics as well as geriatrics and how we can better service those subpopulations. Additionally, patients presenting with mental health concerns as well. We have the opportunity now to provide more isolated care to that population group that is going to be more efficient, more comfortable. I think that our patients will experience a much more pleasant as it can be, a journey through the emergency department. I'm looking at this from myself as I'm not only chief of the department, but as well a frontline worker. And I've serviced the emergency department for 14 years now. I've experienced the night shifts and the day shifts. And I can say that the new model will provide more comfort and less stress to our patients. And certainly our physician group is quite excited. If you can imagine having a blank slate and saying, what's your ideal workplace? Well, certainly working in more older facilities, you have to work around what you have. We have the opportunity right now to say that, you know, we want to bring the best care possible to our community here in Windsor. So what do we need to do? What resources do we need? How do we need to lay this out so that we can do that? And so that in itself is a very exciting concept and a unique opportunity. It's a once in a lifetime opportunity for a physician to be able to give that type of input. Most of us are looking at this from a perspective of we are of this community, our roots are here, our family members are here. So when I look at the layout of the emergency department, I want to say, well, if my father came through or my mother or my own child, what type of experience would I want for them? And so many of us are looking at that from that perspective in terms of how we can make this the best and most efficient experience possible for our local community. So that's our goal with this. And I welcome certainly any type of suggestions. And I'm very honored to be able to participate in this town hall tonight and look at what other perspectives are out there.
Thank you. And Dr. Ninkovich touched on some of that energy that I've talked about from the beginning of the year. There really is, you know, going on 2 years of a pandemic and, you know, seeing and dealing with COVID every day, being able to talk about the future and how we can change it and how we can make it better for our staff, for the people we work with, for the community, for our families. It really has been a really nice change of pace and a unique opportunity. And with that, Kristen, I want to ask you, when you're at these user group tables talking about the future, what are some of the important considerations that your team has top of mind?
Hello, everyone. Just like everyone on the call here today, I'm really excited to participate in this town hall and really excited to work with everyone on the panel as well as our community to ensure that we provide the best care. And like Dr. Ninkovich said, this is a blank slate for us, and we really want to hear from the community to see what you need and what you want. This is an opportunity for myself, my family, my friends, and everyone to have a voice and really share what they need out of the hospital as well as our emergency departments. So thank you for having me here today. One focus for our team is really focusing on streamlining access to care throughout an entire journey for a patient. So working with other partners within the hospital and specialty services for a patient's entire journey. So one aspect of this is really physical space and flow. And that's something that one of our challenges that we currently have at both sites that we work through and working with our team to ensure a smooth patient journey. So we're really looking at this to provide efficient and effective team workflow to provide optimal patient care and the best patient journey possible.
Thanks, Kristen. So throughout this planning stage, the user groups are working closely with consultants from Agnew Peckham Healthcare Planning. And this team has been involved in the planning of many of the largest and most recent new hospital projects in Ontario and really across the country, including the Ottawa Hospital, South Niagara, Humber River, and the new Oakville Trafalgar. And Lucy Brune from Agnew Peckham is now going to talk a bit about the work that's being done in this group and trends that her team is seeing in planning emergency services at other hospitals. Lucy?
Thanks, Allison. It is an absolute pleasure for Agnew Peckham to be working with the Windsor-Essex representatives to plan this new hospital. And so I'm just going to share my screen and pull up the presentation. And this is actually the presentation that, similar to what we provided to the user group the first time that we met with them. So what I'm going to talk about is a bit about our approach and some of the key trends in facility ED planning. So first of all, one of the things that is an absolute is that form follows function. So we need to look at the emergency department. What are the functions? How are they going to be delivered differently in the future? We also know that things change in healthcare over time. Change is an absolute. So as a result, we have to make sure that the facility is as flexible as possible. And the focus, of course, is always on being prepared for those changes and ensuring that the focus is always the patient and their family. So as we some of the panelists have already said, we're looking at the new hospital as well as the Willette campus. In stage 2 functional programming, we look at patient flows, and there are different types of patients that come into the emergency department. So for example, at the ambulance entrance and enclosure, and of course we're assuming that it is an enclosed area so that it's comfortable for patients, they would not be waiting in the hallway on stretchers, but in a designated area that is comfortable, and then they're triaged and would go to the appropriate zone. Of course, the size of the department is based on what the projected number of visits are. And we also need to make sure that the staff have appropriate workplaces for documentation, for their coats and boots, and to have breaks. The adjacencies is about what are the other departments that have to be close to the emergency department. So what we're trying to do is direct the architects in terms of what should be drawn. So the emergency department has to be immediately adjacent, so share a wall with imaging so that the patients can get radiography, ultrasound, CT as quickly as possible. There also needs to be a large elevator, often called a trauma elevator, connecting to the critical care unit, surgical suite, inpatient units, and obstetrics. And so all the circulation routes have to make sure that that's facilitated. And what this then leads to is detailed space lists. And in the emergency department, actually, I think it's one of the biggest, longest list of different rooms that are required. And we also organize it in zones. So obviously there would be areas for walk-in patients, for patients arriving by ambulance. There would be other zones and areas for resuscitation, as well as for mental health patients, for children, et cetera. And I'll talk a little bit more about those pods in a second. As Paul said, we're looking at both the 10-year projections and the 20-year projections, and we established quite a precedent. The first time was with Oakville, where we were allowed to program for the requirements 10 years after opening, as well as 15. So, it's important to do that because there is population growth and aging that will occur beyond the day of the new hospital and the renovated Willette campus opening. And all of this information goes towards informing the architects in terms of what needs to be drawn. And that is shown in that little drawing on the right-hand side. So in functional programming, we look at functions. What are the functions that are going to occur in the space? We look at key operational processes, and in particular, staff, patient, and materials flow, because that drives all the key adjacencies and the key requirements within the department. For workload, that's basically the current and projected visits, and we look at it in not just in total visits, but also the breakdown by what's called CTAS levels, which reflect the acuity of the patients. And then the staffing, as I mentioned, is important to know in order to know how many workstations, how many lockers, and also how many seats in the lounge for breaks. The planning and design section, so this is section 6 of the functional program. We document the key departmental adjacencies, the organization of the space and zones and pods, and the numbers of rooms within each of those zones or pods. And then finally, we have a space list, and the space list lists what rooms, how many, how big, and we try and list them in the order that they need to be close to each other. So there are a few emergency planning trends, and some of these have evolved recently, I'm going to say over the last 15 years, and some of them, like infection prevention, there have been some adjustments as a result of COVID. So under organization of the treatment areas, so we, about 20 years ago, there was a trend to have much smaller zones or pods, like, maybe 12 treatment areas in, and that's it. And it was completely separated from the others. Now they are connected, and there is lots of flexibility to shift into an adjacent zone or pod depending on the acuity of patients. We've also done a lot more for mental health patients, where there is actually a designated zone or pod with an environment that's more conducive to the needs of patients with psychiatric problems. There's also an ability to close off various pods or zones, especially during outbreaks. And as I mentioned, diagnostic imaging has to be immediately adjacent to minimize the numbers of steps that are required to get patients the essential diagnostic imaging. The sizes of treatment rooms have also really increased. So in the 90s, I think we thought 80 square feet was huge. Well, the standard exam room now is 120 square feet. And of course, there are some larger rooms for critical care, bariatric patients, for families, if there are more than, 1 or 2 family members accompanying the patient. And then, of course, with the trauma resuscitation rooms, they're 300 square feet. The infection prevention and control has, what we learned actually during SARS was that there was a need to enclose rooms. And so the open design is no longer part of current standards. Patients would have at least 3 walls around them, and the capacity to enclose the front as well. There's more airborne isolation rooms. So these are rooms with negative pressure as well as an anteroom. And so we would see in the new hospital at approximately 10 airborne isolation rooms. And of course, more washrooms. And our current trend is, our current standard is about 1 washroom per 6 patients. Some rooms, of course, will have adjacent washrooms. And then also through COVID, what we learned is that the entrances we have to have an entryway and an exit at each of the, at the walk-in entrance. We also need to make sure that there's a screening area. And we've also learned that it's important to be able to enclose the zones or pods to make them completely negative pressure. For operational efficiency, many hospitals have put electronic charting ability right outside of the room as well as inside of the room. There's a new trend that's been in place for, I'm going to say, about 10 years now, where there isn't a big waiting room at the front. You're basically triage, and then you go to the zone and or pod that's best suited for your needs, and you would wait in that area. And then also, if you don't need a whole exam room after the doctor or the nurse have examined you, you could sit in a recliner and have your IV or your blood transfusions. And of course, again, infection prevention, you would be screened off from other patients. And then finally, the most important, patient and family-centered care. So as I mentioned, the rooms are larger to accommodate families. There's the decentralized waiting areas, so you don't feel like you're in a big airport. There's more washrooms. There's an offload or an ambulance drop-off area. And there's also decentralized registration so that you don't have to necessarily only be registered at the main desk. So those are the major trends, and here's some sample layouts in terms of the big blocks of space. So this was a hospital that was programmed and about 15 years ago, and then the functional program was updated, and the hospital opened in 2015. And what you'll see here is that there's an ambulance enclosure. So this is the ambulance entrance, and there's the walk-in entrance with the triage. And most of the acute care patients are in this area, closest, of course, to the ambulance entrance. And the ambulatory urgent patients, so these are less acute, would be closer to the walk-in entrance. And then there's a psychiatric area, mental health area, and of course, imaging that's accessible from both the acute and the ambulatory urgent pods. In the second example, this hospital was also opened actually about 7 years ago. The original functional program identified that it was going to have 97,000 visits, and I think they are now up to about 150,000 visits. And that's where flexibility comes in. The ambulance enclosure is the closest to the acute resus area, which is right here, and other acute treatment areas are here. And the pediatric pod is actually right here, but able to expand into the rest of acute. And the ambulatory urgent area is actually in 2 subzones, but of course they have the flexibility to move between them. This is the mental health area and the imaging area close to all of the treatment areas. This hospital was programmed about 7 years ago and opened a couple of years ago. And same sort of concept with, an ambulatory urgent area, an acute area with the resuscitation in this area, and then monitored beds over here, the psychiatric area, and there's a satellite imaging area here, just like in the previous example. And this looks like there's a lot of space in between, but in fact, that's where the offload area is for patients before they're triaged into this area or into this area. And this is the, most recently opened hospital about a year ago. And they actually have, in this area right here, their offload, right? And so it's also close to triage, the mental health area, separation of the acute and the ambulatory. And this is basically the main road through the department. And this is the entire imaging department with, of course, radiology, ultrasound, and CT, the closest to the ED. So that's the end of the presentation. I could talk about this for the next 2 hours, but I'll stop there.
It's always interesting when you talk about this, Lucy. So thank you for the presentation tonight. We do have a lot of questions coming in. We just have a couple more panelists who we want to hear from, and we promise that we will get to as many of these as possible tonight, but please keep the questions coming, and we're going to start taking those shortly. But right now I want to bring our community and our patient representatives into the conversation, starting with Chief Crowder. Chief Crowder, you bring a unique perspective to the table here, overseeing ambulance services in Windsor and Essex. What are you listening for, and what are you bringing to the conversation during these planning meetings?
Thanks, Allison. And again, remarks of everybody else. I'm proud to be a part of this panel. I'm proud to be a part of the planning team of planning the hospital system for the future for Windsor, Essex, and moving forward. For that question, what I'm looking for, number one, is the flow within the emergency department and the flow throughout the hospital. I don't think it's any type of news flash that offload delays have kind of been a sore spot for decades within the hospital systems across Windsor and Essex County. And the biggest part is flow. How do we move the patients effectively and efficiently? With the type of planning that I've been a part of and some of the discussions that we've had, it's about the improvement of the flow, because we know the numbers aren't going to go down. The numbers are still going to go up. I know that we've had questions of, can ambulances go to the OLET site once it's built? Yes. We spoke to that earlier, of destination protocols. We do that now. For example, if we pick up a trauma patient in Leamington, we don't go to Leamington Hospital or Erie Shores Healthcare. We take that patient to the most appropriate facility, and that's OLET campus that has the trauma center. If we pick up a labor and delivery patient in Bell River, they go to Met campus, labor and delivery, or if they have to bypass OLET, they go there. The system's not going to change in that fashion. I don't expect it to change. If anything, I expect it to get much more efficient for better flow for the patient and their families. The other thing that I look for, and I'm very cognizant of, and this panel is fully aware of my piece on this, of making sure we understand where the volumes are going, where the population is going, and where the demographics are going, so that we can plan the site to expect and handle any increase that we have in the area. We know that population and demographics is growing exponentially across the region, and we have to be prepared for that as we move into the future.
And I think that you answered this question here, but we do hear concerns that people will not be able to get to the new site. Is this something that concerns you at all?
No, it doesn't concern me whatsoever, because Essex Windsor EMS and Windsor Regional Hospital, we developed destination protocols before any other area in the province of Ontario developed destination protocols. We've been doing it for close to 3 decades right now, where cardiac patients go to the right place, trauma goes to the right place, and all of them, even dialysis, we have destination protocols for that. So as the new site is built, as OLET campus is transitioned to more of an urgent care center or an alternate ED, we will develop those destination protocols as appropriate, and to make sure that the patients get to the right place at the right time.
Thank you. Next question is for June Muir. June is a patient rep, and as a patient rep brings an important lens to the conversation. And June, I want to know what considerations are most important for you when you're at this planning table, and why.
So hi, Allison, and I just want to say it's an honor to be here tonight working with this team. The following are important considerations to me. Easy access to the emergency department with ample parking, very close. An expanded and redesigned emergency department, so patients' capacity can be increased, so no one is in the hallway waiting. Immediate triage and sent to a waiting area that is determined by the patient's illness. So I'll give you an example. So if someone comes in with a heart condition, they would not be waiting in the same space as a child with flu symptoms. A conference room for patient privacy, clear directional universal signage so people can find their way. The decorating, it should be bright and cheerful so you don't feel like you're in a hospital. Ensure there's a cafeteria close by that's open 24 hours, 7 days a week. These considerations are so important to me as it will make the experience for my family and myself as pleasant as it can be when using emergency services.
What's it like being part of the planning at this planning table with this team?
Well, I have found it to be a pleasure. The planning process so far has been excellent. It's a very comfortable atmosphere where you can feel that your ideas are not being judged. And I'm learning a lot. So it's great to be part of a planning committee that's so knowledgeable and has the expertise. We have the expertise around the table, and together we're going to create and hear ideas and make sure that there's an emergency service that everybody's been waiting for, Allison.
Thanks, June. And right before we go to questions, I want to go back to Jonathan Foster one last time. Jonathan, what are you hoping to hear from patients throughout this, and why is it important to get that perspective?
Thanks, Allison. I can't overstate the importance of hearing feedback from patients and family members in our community in this process. I think that this planning process is really a good light at the end of the tunnel for all of us who have worked these past 2 years through the pandemic and will continue to face that in the foreseeable future. But this planning project is the future of healthcare in Windsor-Essex. And the beauty of having people participate, whether you're a community member who's never had hospital services or you're somebody who's used our services a lot, is that when we do have this project created as a community, we can say we shaped this together. And I think that's so important. Windsor-Essex is a really unique community. And I can tell you that the suggestions and feedback that we've had so far from patients and families are often things that our clinical teams or planning teams may not have thought of otherwise. And I think the suggestions that we heard from June, and I have to really highlight June's role in this, are perfect examples of that. Those are things that are patient facing, that are going to really impact the patient experience and really work really well alongside the medical planning and the planning that the clinical team goes through. So we really want to hear any ideas, any suggestions. It's like a community brainstorming session. And then as a team and working through the process, we can find ways to incorporate innovations and best practices and new things. And I just can't think of a better moment than somebody walking into our hospital and encountering a service or a feature of the hospital and saying, that was my idea. I suggested that and it made it. So that's really why it's important. And we really are grateful for everybody who's participated so far. And we really encourage further participation.
Thanks, Jonathan. And in addition to tonight's town hall, we do want to invite you to visit our engagement website at togetherwebuild.wrh.on.ca. And there you can provide input on emergency services, as well as 11 other areas of planning for the new hospital. It's kind of cool. You go there, you can post your ideas. So you see it live, you can comment on other people's ideas and suggestions. I was on there today. There were people talking about having separate spaces in the emergency department for different groups. There was somebody, a resident at who's working at Humber River right now, talking about some of the items that she's seeing during her rotation there that she thinks would benefit patients here, and she provided a list. So I do encourage everyone to check that out and contribute and add on to that. You can also complete a series of surveys where you can let us know what you would like to see in the new hospital. And we do really, again, want to hear from you. And now we are going to go to questions from the audience now. And the first one comes from Carolyn Taylor, who wants to know, Jonathan, what is the difference between a UCC and an emergency department, an urgent care center and an emergency department?
Thanks for that. And thanks for the question. I think it's a really good one to answer. Most importantly, because this is not technically an urgent care center. And I'm just seeing a note in the chat that we may have lost a video, but
no, you're on.
We're good. Okay.
Yeah.
All right. Sorry for that. Web technology at its best, even during this. But back to the question. This is much more than an urgent care center. So and that's why we're calling it a satellite emergency department, because beyond what is in a typical urgent care center, we're going to have CT available, we're going to have X-ray available, pharmacy and labs, and that really enhances and expands far beyond what you would typically experience in an urgent care center that's standalone. And working in tandem with the emergency department at the new hospital location, and as I mentioned before, having the same staff really takes it to a different type of model. I hope that helps clarify that.
Thanks, Jonathan. Another question for you, and this one's from Missy. How will mental health emergencies be addressed within this new model? With Hotel Dieu Grace becoming a center of excellence for mental health, will a mental health emergency room be established that you transfer to from other emergency departments?
Thanks, Allison, again. And I can just comment on what we've been planning so far. I don't know if it's my video that's gone, but anyways, I'll just keep talking. In both the emergency department at the new hospital location, as well as at the satellite OLET location, there will be specialized spaces within those plans. And in Lucy's presentation, you would have seen some of those. And that really is going to create a specialized patient-centered area for patients coming in with mental health conditions who need to be treated and assessed. It may be an answer either for Lucy or to Paul to talk about what further next steps or planning would look like with respect to the rest of that, but that's where we're at so far. There will be planning that we'll go through to look at how patients will need to get to the right location. And again, maybe turn that to Lucy and Paul.
So the Hotel Dieu will also be planning for the renovation at that site, because they will have the 68 acute mental health beds. But in terms of what, the bottom line, regardless of what organization has what role, is that when a mental health patient arrives at an emergency department, there should be an appropriate environment for them. So that's what we're trying to achieve by having these psychiatric emergency services areas in terms of space planning. But once Hotel Dieu starts their planning process, which we assume will be fairly soon, we will be working more closely with them in a collaborative way to define the space for mental health patients at all three sites.
And Paul, did you want to add anything to that?
No, I think that's good. Thank you.
All right, Jonathan, this question.
Allison, perhaps I can just add that these mental health patients will be assessed and managed for their acute illness and stabilized at either site. And then further arrangements will be made for transfer once stabilized to the Hotel Dieu site.
So really be working together. And I think that also answers a question that Vanessa had here. Thank you. A question, I'll throw this one out to Jonathan, but really for anybody, will there be inpatient beds at the OLET site?
At this stage, not planned, but again, turn it over to Lucy or Paul for further commentary on that.
The stage 1 submission did not include beds. That the vision was that all inpatient beds would be at the new main hospital. So those are the acute beds, and then acute mental health The specialty mental health and other post-acute beds would be at the Hotel Dieu site.
Thanks, Lucy. We have a question here from somebody who wants to know, why is it taking so long? And maybe I can put this one to Paul. Paul, you've been a part of a lot of building projects, and there is so much that goes into the planning of a hospital, especially a hospital of this size. So maybe you can tackle that question.
Well, thank you, Allison. Yes, starting with a hospital of this size, often referred to as a mega hospital. This hospital will be, over 1 million square feet, and hospitals are amongst the most complex buildings that there are to design and to construct. We often talk about, as planners, all of what's behind the ceiling and behind the walls, which is almost 50% of the cost of a new hospital project. So that sort of speaks to the amount of mechanical and electrical systems and the complexities of that. So it takes time to plan a hospital, and you have to start conceptually, sort of where we are now, a little beyond the concepts, in developing a functional program and a very specific long list of thousands of rooms that serve specific functions, whether they're treatment rooms or whether they are offices or they are family meeting rooms or exam rooms and so on. And how do you properly organize them so that you have an efficient patient flow first and foremost, so that we have the best patient experience possible, but also the best staff flow and back of house, logistics and supplies delivery and so on. So we start with that, and we develop block schematics. And as I outlined in the 5 stages, we move progressively into more detailed plans. The procurement process in stage 4 is reaching out, of course, more than reaching out. It's putting out tender documents. It's putting out an RFP to recruit a developer, constructor, another design team to further those plans right into detailed design and working drawings in order to be able to construct a massive building like this one. And so that process alone is pretty extensive. I've been part of it in previous projects, and it takes months to put a package like that out into the marketplace and have bidders respond to those bid documents, and to then select one through a very, very detailed evaluation process, and then have them, as I just mentioned, further that design and have it then ready for construction. And in between these phases is, of course, the ultimate decider, which is the government, the Ministry of Health and Treasury Board. When we're actually fully ready, we've answered all of the questions, our plans, both from a programmatic perspective, but also detailed plans, have been costed. And from a budgeting perspective, they are ready for us to move forward into construction. It takes time. So it's not something that, and every project is unique. The volumes, the size of the hospital, and how it is planned to respond to the community, the region's needs for the next 20 years and beyond is unique to Windsor, Essex. There are other large, beautiful hospitals in the province, and they respond to those communities, whether it's Mississauga or it's Vaughan or it's Niagara. And so we need to go through this planning process and submit after every stage our reports to the ministry. They review all of that and respond to us and say, yes, you've answered all of our questions. Your plans are very clear. It's now time for you to move into the next phase. Sometimes that review process can take 6 months to 12 months, depending on what we're proposing to them. we will be proposing a significant amount of growth in this new hospital. We have learned a lot from the pandemic in terms of surge capacity and what we will need for, for the future. So those are very new in terms of, planning volumes and planning bed capacity and services capacity for the future. And the ministry needs some time to really delve into all of that, review all of those details, and then respond to us and give us the green light to move forward into subsequent phases. And that's why it takes the time that it takes. So we've mapped it out, and if all goes well with the ministry's review process, we hopefully will be able to get the shovel in the ground in the summer of 2026, and with a 4-year construction project, hopefully be in a position to be opening the new hospital, as well as the Willette site. There'll be obviously some renovations there that will occur, but in the summer of 2030. I hope that answers your question.
It does. And I want to just keep going on that one for another question that we have here, because you talked about, it will be bigger. Do we know how big it will be in terms of the bed count in the emergency department? Will it be higher than the current combined ED count? And if so, how many is the question?
Well, I think, do you want me to start with that, and perhaps Lucy could expand upon it? It will be larger, and I think, as we said at the outset, we are still discussing how much larger, on which site, and we're not quite there yet in terms of concluding those discussions. We're analyzing volumes, we're looking at all of the different types of cases, and really getting quite specific about how we're allocating those cases between the two different sites. And of course, those volumes are what drive the number of rooms that we need, the different types of rooms that we need, treatment rooms on each of those sites. So I think that work, quite honestly, is underway. And I think that we are on track for having those details near the end of this functional programming process. But Lucy, did you want to add any more to that in terms of, what the projections for the future are pointing us to in terms of treatment places and beds within the ER? We should probably refer to them more as stretchers within the ER.
Or rooms within the ER.
Or rooms.
Yeah, sure. Yeah. All the projections are based on the demographic projections, and they demonstrate that the population is growing and aging. And as we know, older people need more hospital services. So absolutely, there will be more beds, more visits, more outpatient visits. So, but we haven't finalized the discussions within the user group around how that translates to the number of treatment areas in the emergency department. We're having a meeting in a couple of weeks, and hopefully at that point we will have more of more definitive projections about what will be the numbers at both sites and how many treatment stations at both sites.
Thanks,
Allison,
Lucy.
I just wanted to add that perhaps by the fall, when we have our next round of town halls, we can provide definite information on all this data and all the projections.
Yeah.
I think that's what's going to be nice about this, is you'll be able to see the planning. And I mean, that's the purpose of this. We want to invite everybody on this journey with us. And right now it is very early in that journey.
Allison, can I just jump in too on that? Like, one of the things that we've learned over the past few years is that our spaces have to be nimble and flexible. And so as we're talking about spaces, we need to be able to surge up when it happens, and we need to be able to collapse. And I think the analogy that we used, which I liked, was like an accordion. And emergency department volumes flow like that. So one of the really great parts about being able to design and build these two new spaces is that the space and the layout of it is going to be conducive to that So there's a lot of questions about how this is going to impact our patient experience. How is it going to help flow? That's one of the key features for this. We're working out of two very old and aging infrastructures right now. And under the current setup, the challenge with operating between those locations as they are is significant. In this new setup with these new innovative state-of-the-art designs, it's really going to maximize how we can efficiently use the spaces that we have. So notwithstanding the great planning work that's being done, that's a really key design feature and probably one of the most exciting features of it.
Thanks, Jonathan. Lucy, a question for you, because I know that your team has looked into this. What lessons will we learn from COVID? In particular, how will we ensure that there are more private spaces, and which ones are negative pressure capable?
Thanks. Great questions. So as I mentioned earlier, the shift in hospital planning actually occurred after SARS, and we had done a review of the facility implications of SARS in 2003, and we started to adjust our space programming. That was also evolved into almost Canadian standards. And there is something called the CSA Z8000, and that outlines the rules about hospital planning. And one of the rules is that all the patient rooms have to be single rooms. And the Ministry of Health is actually supporting that, absolutely. In the emergency department, as I mentioned, many hospitals are choosing to at least have the capacity to enclose all of the rooms. And that's all about contact isolation. And then the negative air that's required for airborne isolation would be in the number of airborne isolation rooms. So we've worked with infection prevention and control, Erica, and we've gone through all of the clinical areas and said, okay, what's a reasonable number of airborne isolation rooms? That's not finalized yet, but I would, I would suggest that in an emergency department, at least I'm going to go out on a limb and say about, 1/10 of the rooms would be airborne precaution with anteroom. And then on a medical surgical unit, it would be about 3 of the 36 beds would be airborne isolation, so slightly less than 10%. So lots of other lessons learned from COVID, and we did a research study because we wanted to make sure that the planning that we were doing for the new Ottawa Hospital, new Mississauga, that there were the learnings from recently developed hospitals, and that we could then apply them to the ones that are just a little bit further ahead than the Windsor Regional project. The Windsor Essex Acute Care Hospital. And so that's the other benefit is that you're a little behind, but you're also getting all the lessons learned from those projects as well.
And how much do we look to other hospitals? Like, there are some questions on here, why don't we just pick a hospital that's been built recently and build that hospital in Windsor, Essex? And how much do we draw from that?
Right. So we absolutely draw, but we're constantly improving. So, for example, the Humber Hospital, we programmed in 2010 after several years of work, but let's say that was a 2010 program. That's already old. It doesn't fully reflect everything that we had in the lessons from COVID. It didn't have all 1-bed rooms. There are a lot of changes that we would make as a result of that learning. But absolutely, we could do that, but then that wouldn't really be progress. You'd just be getting something that was developed 12 years ago and didn't have all those other learnings. You're on mute.
I'm on mute. It took more than an hour to get to the point where someone was on mute. So I'll be the first person there. And if anybody's playing a drinking game, I'm sorry I made you wait that long. A question for Jonathan. When will the new satellite emergency department open?
That's a good question. The opening of the new satellite emergency department is a real integral part of the plan. And what we're working towards is have them both open at the same time. So they'll both be functioning at the same time.
Maybe, can you address this one too? Will Leamington still have its hospital?
I think that's probably out of scope for this conversation. There's nothing in our planning that, other than working with collaboratively with Erie Shores as another emergency department, another acute care site. And we work very closely with them in the current state. And I know that we'll continue to move down that collaborative journey.
And I do know that throughout this conversation that we've been having for many years now, that Leamington is an integral part of the system that we have here, and there's nothing that's happening as part of this planning that is looking in that direction. Jonathan, will the Olette satellite site and the main new hospital be built, renovated? Oh, you already answered that question. Thank you, June. Wonderful patient perspective. Could we hear more about the diversity of patient perspectives at the planning team? Paul, do you want to start on that one and I can pick it up?
Sure. So what we've done is we have, for many of the clinical areas that we are planning and developing the functional program, we have onboarded, welcomed patient representatives to the planning table, like June. So in these town halls, we have planned 11 town halls, and we have several patients that will be joining us for those town halls to share with the community their experience in being at this table and really listening to some pretty interesting discussions. I'll even say debates around volumes, around numbers, around best practice, around all of the, the various services that we will have, for example, for the emergency department, but for all of the other clinical areas as well. So very happy to have them involved. They bring a unique perspective of that patient experience, having been to, through different clinical departments, and they're bringing, that perspective to the table so that we are considering certain things that they experienced, maybe privacy issues, maybe flow issues, maybe lack of space issues. And so it's tremendously, I think, enriching and a value added to have those patients at the planning table with us. We have 15 patients, I think, in total on various teams. And as I mentioned, several of them will be joining us for these 11 town hall meetings.
And I know, Allison, maybe I can add, we have special or additional functional planning groups for spiritual care, as well as for the Indigenous population, which I think is really very important in our community. As you started off our discussion today with the reading of the Indigenous logo, that this is all very important for our community as well.
Absolutely. And these are not conversations that start today or end today by any means. Bringing the patient perspective into this conversation started many years ago, right from the beginning. I know the Program and Services Planning Committee for the previous stage, this was very important to them. And we went out during that time period and spoke with more than 70 different community groups about what was being planned, different ethnic communities, different cultural communities, municipalities. And then this time around, because of the situation that we're in, I haven't met with anybody in person for more than 2 years. We did decide to do it virtually, but we sent this invitation out to all of our community partners, including all of the different cultural groups, the ones that we've built relationships with and the ones that we are hoping to in this stage. And in between now and the fall, when we come back and talk to you again, we'll be out there again, looking to connect with different groups, with whoever wants to listen to us and speak with us and learn more about this project. So next question here for Jonathan, is it planned that the triage area will be larger than the current, and what will be the expected number of triage staff at any one time?
So I'll maybe start that out and turn it over to Kristen. I think we've spoken a couple times about how in the design process, we're talking about what the needs of the department are, how we need it to function, how we need it to flow, and definitely triage and the waiting area have been key features to that. So while we haven't drawn detailed schematics yet, and Lucy talked about how that process will unfold, we're going to give this raw material of what we need to planners who will then start to create the visions and the sketches behind that. But maybe Kristen, you can talk about how the nursing flow is being incorporated into the needs that we're talking about.
Sure, thanks, Jonathan. And yes, we're looking at physical space, and we're also looking at how many nurses we will need. And these are all very preliminary conversations as we do talk about space and what model we're going to proceed with. So it is kind of ongoing conversations. I can't divulge any specific numbers as they're still in pre-planning phase right now, but definitely will be incorporated that in regards to space. As I said earlier, physical space is something that we are challenged with currently. So we're definitely looking at with the new build.
And just on that, with the triage area, we're looking at things like the line of sight to the waiting room, the proximity to offload areas, the EMS entrance bay, and how all of those functions are going to work together. We know that in our current setups, there are limitations because of the space. So again, I want to emphasize what a great opportunity is now that we have this chance to look at a design that's really going to support the clinical flow of patients.
And just to add on that, I know there was a question earlier about access to care, and this is kind of incorporating all of that. Access to care is also streamlining physically where different departments are within the hospital and how that affects the emergency room to ensure patients have timely access. It's physician assessment times, it's services being offered at one hospital instead of two different locations like our current state. So it's a multitude and it's multifactorial, but that's all being discussed at this planning committee. And this is definitely an opportunity for the community to have a voice in that.
Thanks, Kristen. Lucy, a question for you. One of the participants wants to know, why are we planning for recliners here? Why not build with rooms and beds instead of recliners?
So that's a great question. There will be lots of rooms with the stretchers, exam tables, but in particular, in the ambulatory zones that I pointed out before, patient doesn't necessarily need to lie down. So for example, I twisted my ankle and I went to the emerge, and the doctor examined my ankle. I was fine just sitting. And then I went, and so I didn't need to take up 120 square feet. I just needed really, a seat that was 15 square feet, a recliner's 40 square feet. So it's all about within, and there will be a limited space budget in all departments, and that the ministry will only approve a certain amount. And it's part of all of this is, how do you maximize your flexibility by the type of space that you program. So I'm not saying that they will all be recliners. It's just that in some areas, in terms of making the patient flow move, you might not want to have somebody who's just twisted their ankle in 120 square feet.
Thanks, Lucy. A question for Kristen. Access to care was mentioned previously. Could the presenters describe what specific barriers will be addressed through this new model?
I kind of added on to the last question in regards to access to care, but just reiterating, there's services right now offered at different sites between OLED and Met Campus. So that being a solution with this hospital, that services would be offered at one campus is a big win for the community, as well as physical space and just ensuring that our care partners and services within the hospital it's timely.
Thanks, Kristen. For Jonathan, I'm wondering if there will be any space for geriatric patients who are determined in the ED not to need acute care or hospital admission, but are waiting for long-term care and they can't return home.
So 2 parts to this answer, and another really good question. Maybe 3 parts. So part 1 is throughout the Emerge, we're really looking at making sure that the spaces are patient-centered and really suitable for a variety of patient populations, so that if we do have geriatric patients, I think the earlier comment would be that they may not be positioned directly next to a pediatric patient. So that's part 1. Part 2 is through the overall hospital planning process. We're talking specifically about the emergency department now, but there's still a lot of work underway on the inpatient side of things. So the goal would be, just like we're going to have sufficient emergency spaces, we're also going to have sufficient inpatient beds so that if patients do need to be admitted, we are able to admit them. And then the last part, and probably the hardest one to answer in this question, is how do we help patients who may need to go to long-term care, may need resources in the home that they're not having access to, and they don't essentially have a place to go. And I can tell you, we work case by case over scenarios like that every day right now. And we work really collaboratively with our home and community care partners, with our Hotel du Grace partners, and we always try to find the best patient-centered solution. And in the event that we can't, we always take care of a patient. And I think, again, knowing that we've got really a kind of a specialized custom approach to the spaces in the Emerge, as well as the work underway for inpatient, that work is just going to continue.
Thanks, Jonathan. Another question for you. Of the patients who present to the emergency and don't need to be admitted, what percentage of their visits are completed without any further need for follow-up treatment? So what percentage of visitors to OLET urgent care are you expecting to require further appointments or treatment at the hospital itself?
I think that many physicians do that type of follow-up with those clinical appointments and bookings out of their own private offices following. And I think that we know that that's really the trajectory that patients go. There's ongoing examination right now from the Ministry of Health to ensure acute care hospitals focus on acute care and community visits occur in the community. And that's a lesson that we've learned throughout COVID, and definitely one I know we're going to continue. So again, the short answer to that is that there would be few or select visits that would need to be followed up within the hospital. And those that do will be scheduled and proceed, whether you're going to the satellite location or to the main hospital. But again, most of those visits should and will be taking place in the community, in community offices.
Lucy, we have a suggestion that maybe all of the rooms should be airborne isolation rooms at this point. Is that doable or something that you've seen anywhere?
Haven't seen that anywhere. If all the rooms are enclosed, like they are, for example, at the Oakville Trafalgar Hospital and Humber River Hospital and the new Mackenzie and the new Etobicoke Hospital, then you have 100% contact isolation. So that's possible that you can isolate 100% if what they need is contact isolation precautions. If they have an infection that is airborne and you need negative pressure, so not only do you need negative pressure in the room, but you need an anti-room to ensure that that pressure is maintained. It becomes very expensive in terms of the size of the room, as well as all the mechanical systems. So when we did our facility implications of COVID research, part of the question was, was there an insufficient number of airborne isolation rooms, or what rooms were too small or missing, or insufficient number? And we didn't hear there was, that every room had to be airborne isolation. We did hear that there needed to be a few more airborne isolation rooms. But I would say that in the past, there would probably have been about 5% of rooms that had that were true airborne isolation. And I think that we're doubling that in more recent programming.
And just to add to that, Allison, all departments, all areas in the hospital will have those particular types of airborne isolation rooms. pediatrics, maternal newborn, the OR, emergency department, inpatient units, med surg. We'll all have those types of airborne isolation rooms available. Intensive care unit as well.
Thanks, Dr. Petrakis. And I think that's bringing us to a close tonight. I do want to thank everybody who joined us. And I know that this time can go quickly. There are still quite a few questions left that we did not get to tonight. Once again, we do invite you to visit our engagement website, togetherwebuild.wrh.on.ca, where you can continue this conversation, post your ideas for the future emergency departments, take the emergency department survey, take all the surveys, and ask any questions that didn't get addressed tonight. I think we did address very many of them, or any questions that come to you after the fact that might have been triggered by something that you heard tonight. This site that I'm talking about here, this will remain live for 1 month after the town halls. So you can continue to share your thoughts there. And following that, the results will be summarized and they'll be shared with our planning teams. They'll be posted online and they'll be shared with the planning teams going forward as well. So your input will help guide the decision-making process. So please, please take the time to share your thoughts. And then later this year, we will do this all again. You'll have a chance. I see Dr. Petrakis is smiling there. So yes, 11 more town halls in the fall. And you'll have a chance to see how the planning is progressed. You'll have a chance to see how this input has been used in the planning. And as Jonathan said, when we finally open, we hope you come through the doors and you'll see that input at that point as well. I do want to thank everyone for being here with us tonight and taking this journey with us as we plan the future hospital. I hope you'll join us tomorrow at the same time when we're going to take a look at outpatient services. And I really want to give a special thanks to our panelists, all of you, for your time this evening, all the work that you've done in this user group, all the work that you've done in the hospital and in our community. And for the final word of the night, I'm going to call on Jonathan Foster one more time, and he'll send us off for the evening. Jonathan?
I don't know if I have anything super profound for you, Allison, but I will say this. Our emergency departments are often the front door to the hospital, and I think it's kind of coincidental but fitting that this town hall got scheduled first in the group, because it really does follow through that cycle. It's no secret that our emergency department is at times under tremendous pressure, but I want to reemphasize that this is the exciting part. This is the positive part, where we can take some of those challenges that we've had, work collaboratively with all of our partners, and most importantly, get the feedback from our patients, our families, and community, and design something that's really going to serve us well, that we can all know that this is our community. This ED is for all of us. So when we're done, we know we're going to have the best emergency department that we could have planned. So I also echo your thanks to everybody who took the time to ask questions, even the tough ones tonight, and to continue to take part. We're in this together, and we're going to continue down this journey. So thank you.
Thank you. Thanks, everyone. Good night.
Thanks, everyone. Good night.
Good night.
Good night,
Everyone.